Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for this clinical clip in hypertrophic cardiomyopathy. I am Dr. Maron, Director of the Hypertrophic Cardiomyopathy Center at Lahey Hospital in Burlington, Massachusetts. In this clip, I will highlight the key data presented at the 2025 ESC Congress in Madrid, Spain. So thank you for joining us. So it was a really exciting meeting. There is really no question that there was an enormous amount of focus and attention on hypertrophic cardiomyopathy, highlighting and really underscoring really a number of really important advances, which of course I'm going to highlight over the next 10 to 15 minutes. And I'm going to start really with a trial that in many ways may impact significantly the way we approach the treatment of symptomatic obstructive HCM. And this was the MAPLE HCM clinical trial. It was a phase 3 trial evaluating a cardiac myosin inhibitor, aficamten, in the management of symptomatic obstructive HCM. And so before I kind of get into the trial, let me just give a little bit of background so that we can understand the results and really understand how to translate those results into management. As many that are listening may have appreciated over the last 5 to 10 years, we've had the emergence of novel medical therapy for obstructive HCM in the class of drug called cardiac myosin inhibitor, with mavacamten first in class and aficamten second in class. Aficamten is still under investigation. Mavacamten is approved for the treatment of symptomatic obstructive HCM, both in the United States and in many other areas and regions of the world. The evidence for both mavacamten and aficamten is that those drugs, through other phase 3 trials, have been demonstrated to improve how patients feel and how they function with symptomatic obstructive HCM. And they've done that because those drugs are very effective at lowering the left ventricular outflow tract gradient, translating into clinical benefit. As a result, both the US and European guidelines have underscored that benefit by saying that those drugs, cardiac myosin inhibitor drug, can be considered, mavacamten, again, the only one approved, can be considered in the treatment of symptomatic obstructive HCM as add-on therapy if patients remain symptomatic despite first-line drug therapy in the form of beta blocker or calcium channel blocker. And so that gets us to the sort of rationale for the MAPLE HCM phase 3 trial, which was testing the idea that aficamten may be beneficial as first-line monotherapy versus the current standard beta blocker. And as many may be listening may appreciate, we have used beta blocker as first-line therapy in obstructive HCM for the better part of almost 60 years. However, the amount of evidence to support that indication has been very, very minimal. And so what MAPLE HCM did was randomize symptomatic obstructive HCM patients to initial monotherapy with aficamten versus initial monotherapy with beta blocker. And these were symptomatic obstructive HCM patients with high gradients, preserved ejection fraction, who are NYHA class 2 or 3. And they randomized 175 for 24 weeks of therapy and then a washout period. And essentially what MAPLE showed was that aficamten was at week 24 superior in treatment efficacy to beta blocker with respect to the primary endpoint of the trial, which was a exercise endpoint of peak VO2. Highly statistically significant improvement in peak VO2 with aficamten an enhancement of about 1.1 milliliters per kilogram per minute in peak VO2, exceeding what we consider to be the clinically meaningful improvement in exercise with aficamten. And actually, beta blocker resulted in a decrease in functional capacity, a drop in 1.2 milliliters per kilogram per minute in peak VO2. In addition, aficamten was highly statistically significant in its treatment effect in nearly all of the other secondary endpoints: gradient reduction, change in biomarker, BNP, symptomatic status based on both NYHA class change and improvement in KCCQ questionnaire. And then to sort of highlight that, gradient reductions with aficamten were acute and sustained, with 40 millimeter mercury gradient reductions on average versus very little gradient reduction with beta blocker. You had substantial decreases in BNP of almost 70% with aficamten, and actually BNP went up with metoprolol beta blocker. KCCQ improvements were substantial at about a 7-point difference between beta blocker and aficamten, and about a 51% of patients, proportional of patients, had an improvement in NYHA of 1 or more versus only 26% of patients had that improvement with beta blocker. In addition, aficamten was safe and well tolerated, with very few patients who had ejection fractions that were less than 50%, otherwise very safe and otherwise well tolerated through the trial. And so, what MAPLE-HCM really sort of underscores really is a principle, an emerging principle, that beta blockers that we have been using consistently for treatment as first-line therapy for symptomatic obstructive HCM are essentially not effective. In fact, decreased exercise performance with very little change in symptomatic status as well. And compared to the efficacy and treatment effect that a myosin inhibitor like aficamten provided, was substantial, that difference. So that starts to support really the idea that myosin inhibitor with aficamten may be reasonable to consider as initial monotherapy for symptomatic obstructive HCM. And that MAPLE-HCM data is really on top of other data that was presented at the ESC meeting, demonstrating that when aficamten is used longer term in symptomatic obstructive HCM, this is data out of the open label extension experience with this drug called FOREST-HCM, that the treatment effect of aficamten is sustained over long periods of time. This was a follow-up of a substantial proportion of patients with obstructive HCM, followed for an average of about a year, in which gradient reductions were again shown to be acutely decreased but sustained over that period of time, again translating into a substantial and sustained improvement in how patients felt as well, with almost 70% of patients who were able to achieve at that 1 year mark or more a 1 or greater improvement in NYHA class, a 15-point improvement in KCCQ. We consider a 5-point improvement in KCCQ to represent a clinically meaningful improvement in how a patient feels, their health status. And BNP levels remained very low through that long-term treatment period as well on aficamten. In addition, very importantly, very few low ejection fraction events, I think 3.4%, and very low incident of new onset atrial fibrillation as well in this long-term experience with aficamten. And so this demonstrates that when we look at this drug, aficamten, over longer periods of time, beyond sort of the acute phase 3 experience, we see very clearly that the benefits are maintained for patients, which is really important because these are patients with obstructive HCM are often young, and we often have for that reason, very long treatment periods. And so we really need to establish the principle that these drugs maintain benefit over long periods of time, and the FOREST data substantiates that. And I want to make another sort of important point, and this is one that has to do with the relationship between myosin inhibitor therapy and atrial fibrillation. And this is on the backdrop of some concern that other myosin inhibitors may be associated with an increased risk of atrial fibrillation. That's not yet fully established, but there's some observations emerging out of longer-term data to suggest that that may be something that we need to keep an eye on. And so it's a really important point because atrial fibrillation is not well tolerated in patients with HCM, and we certainly don't want to be increasing the risk of atrial fibrillation in our patients with HCM through drug therapy. And so in the ESC meeting, there were investigators that presented some additional evidence related specifically to atrial fibrillation risk and aficamten use. And in this study, which included patients that were on aficamten from the prior phase 2 study, the prior phase 3 study, and the open label extension, so it was 173 patients on aficamten, and essentially demonstrating that over a fairly substantial follow-up period, that the incident of new onset atrial fibrillation in patients with HCM on aficamten was low, 1.5% per year, actually lower than what would be predicted for a atrial fibrillation incident rate based on the HCM atrial fibrillation risk score, which would be about 3.6% per year in a natural history HCM cohort. And so that really demonstrates, first and foremost, there's no evidence right now that aficamten is associated with an increased risk of atrial fibrillation. In addition, in those patients that did have atrial fibrillation on aficamten, there was no evidence for increased mortality, acute hospitalization, or arrhythmia. And the clinical benefit that aficamten provides those patients in terms of symptom and gradient relief was also sustained in patients with AF and similar to those that didn't have AF. And so all of this is very, very important because it really underscores with aficamten, again, a very important safety profile, in this case, specifically related to no evidence that there's an increased risk of atrial fibrillation, or in those that do have atrial fibrillation on aficamten, that there's no excess risk associated with that situation. Another hot topic at the ESC meeting, and one that was, very anticipated, were results related to treatment in the non-obstructive HCM population. Non-obstructive HCM, meaning the absence of outflow obstruction, either at rest or with exercise provocation, is present in about a third of HCM patients. And for those patients that develop symptoms and decreased exertional capacity with non-obstructive HCM, we have very little in the way of treatment, as many who are listening can appreciate. If you've taken care of non-obstructive patients, you realize that that is a huge area of unmet medical need. The current therapies, beta blocker and calcium channel blocker, fall short, very short, in providing clinical improvement in the non-obstructive patients. And so it's been an enormous area of unmet treatment need. So that kind of sets the background for the meeting and the data that were presented. And I'm going to start first with a smaller study from investigators from Denmark, who presented a small-ish study of patients with non-obstructive HCM who were evaluated over a prospective, randomized, blinded, triple therapy kind of clinical trial, in which essentially patients with non-obstructive HCM, each patient received beta blocker for a period of time, they received calcium channel blocker for a period of time, and then the same patient acted as their own control. Okay. That was about 32 patients. That's called a triple crossover design. Again, with endpoints there over that treatment period that are the traditional kinds of endpoints like peak VO2 and assessing symptomatic status. So what this study from Denmark demonstrated, and the beta blocker that was used was bisoprolol, and the calcium channel blocker that was used was verapamil. And what that study showed was that in the non-obstructive patients, beta blocker therapy was associated, again, with this decrease in peak VO2, decrease in exercise performance, with no change in peak VO2 with verapamil. Very little improvement in how patients felt on beta blocker, a slight increase with KCCQ, but minimal. No change in symptomatic status with verapamil. In fact, again, BNP went up with beta blocker, down a little bit with calcium channel blocker. So this sort of sets the stage because this was really one of the first investigations that we've ever had looking at these traditional therapies of beta blocker, calcium channel blocker in the non-obstructive patients. And what this small study from Denmark shows really is that the efficacy here is really non-existent, right? I mean, if anything, beta blockers decreased exercise performance in a similar way that we have seen in the obstructive patients, okay? Where peak VO2 with beta blocker goes down, like we saw and talked about with the MAPLE study, with very little evidence that they make patients feel better, either beta blocker or calcium channel blocker. And so this isn't the end. This study obviously cannot represent the end or the final word about beta blocker or calcium channel blocker in the non-obstructive patients because it was relatively small and perhaps not sufficiently powered really to be the final answer here. But I do think it gives us the first sort of look and insight into the backdrop that really we need better therapies clearly for the non-obstructive patients. And that sort of segues into a trial that was very, very highly anticipated, which was called Odyssey HCM. Odyssey was a phase 3 prospective randomized clinical trial of non-obstructive patients randomized to a myosin inhibitor, mavacamten, versus placebo. Okay? And again, compared to the prior study from Denmark, which was, again, about 32 patients, Odyssey randomized in an international situation with study sites all over the world, 580 non-obstructive patients who were on mavacamten or placebo in a 1-to-1 randomized fashion for almost a year, 48 weeks. So really a substantial effort here with the Odyssey HCM investigators trying to really answer the question of, do myosin inhibitor, mavacamten, improve how patients feel and function with non-obstructive HCM? And that was represented in the primary endpoint of Odyssey, which was peak VO2 and a KCCQ endpoint. Okay? And what Odyssey showed was that there was no significant treatment effect with mavacamten compared to placebo with respect to that primary endpoint of peak VO2 and KCCQ, a non-significant p-value there showing no evidence that mavacamten had a beneficial treatment effect in improving either exercise performance or symptomatic burden in the non-obstructive cohort. Now, some of the secondary endpoints were, favorable, but also non-significant. BNP was decreased. However, I think if you look at one of the more important, of course, aspects of any study in terms of novel drug therapy in a patient population, which is safety. Here, there was a substantial proportion of patients who had ejection fractions that were less than 50%. In fact, about 21% of patients on mavacamten had a drop in EF of less than 50, some of which had heart failure as a result of that, and including a proportion of patients who had EFs that really went substantially low, 30% or such. And so really sort of challenging the ability to use this myosin inhibitor mavacamten in this patient population would be the issue of safety as well. But anyways, regardless, no evidence that it provided a clinical benefit with respect to that primary endpoint of feel and function. So very sort of frustrating and disappointing result there. I think there was a lot of hope and anticipation here that we would be able to demonstrate with novel therapy that we could improve this patient population's natural history and provide these patients an opportunity with another drug to improve their quality of life. And that does not appear to be the case, at least with mavacamten. Now, that itself, just to be clear, does not mean that that's the end of the potential for myosin inhibitor therapy in non-obstructive HCM. I will, underscore that there is another phase 3 trial looking at aficamten, and we talked a lot about aficamten earlier and its efficacy in obstructive HCM, both compared to beta blocker and also its long-term safety, just in general, and efficacy in symptomatic obstructive HCM. That's also being looked at, aficamten, in the non-obstructive patient population in a similar kind of trial design as Odyssey. And that study is called Acacia HCM. And I think we'll probably have some evidence of those results sometime in 2026. And I'll just emphasize that aficamten is the same class, but it's also a different molecule than in some ways than mavacamten. And so that differentiation provides the idea that there may be some opportunity here for a different outcome, but we'll have to see. So more to come in the non-obstructive space there in 2026. I'll also emphasize too that one of the other themes that I think kind of emerged here at the ESC meeting, if you kind of put the totality of evidence that was presented about myosin inhibitors, both in obstructive and non-obstructive too, with both mavacamten and aficamten. So this is a principle that sort of kind of transcended both of the myosin inhibitors, is that the observation that these drugs that they appear to have a directionally favorable change in potentially important aspects of HCM cardiac remodeling. Okay. So meaning that these drugs appear to, for example, decrease left atrial size, they decrease wall thickness in left ventricular mass, they have favorable directional changes in parameters of diastolic function. And so that has really raised the question of whether those changes in cardiac remodeling, one, are they an independent change relative to, are they independent of just the gradient reduction in the obstructive patients? But also, more importantly, are those changes that we're seeing in cardiac remodeling, do they offer patients an additional independent clinical benefit? In other words, what's the clinical meaningfulness of changes in left atrial size, wall thickness, diastolic function? And we're starting to sort of see evidence that there may be some association with those changes, providing patients a more favorable natural history, even beyond gradient reduction. But that story is not yet complete. But that's another area of kind of interest and enthusiasm. And I think as we move forward, we're going to get more information about that. And I think if ultimately we can demonstrate that those aspects of cardiac remodeling with myosin inhibitor therapy are providing patients an additional favorable effect, it really elevates at that point even more the overall benefit and impact of myosin inhibitor therapy in HCM. Thank you again for joining us for this clinical clip in hypertrophic cardiomyopathy with key updates from the 2025 ESC Congress. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, or ACPE credit and access the downloadable slides. Thank you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.